Number 11. Number 11 is a critical rule. Ethicists, when questioned in the United States, when they're asked what is the worst thing a physician can do, they say abandoning a patient is the most unforgivable sin. The exam rule is therefore clear. Never abandon a patient. I mean never, not for any reason. Once someone's your patient, they're your patient. All right, now let's do the drill here. I come to you and I want to become your patient. You're a doctor. Do you have to take me on as a patient? The answer, of course, is no. You do not have to take me on. If you don't want to take on any more patients right now, if I'm not in your specialty, if you're just too busy, all those are reasonable reasons to simply not take a patient. Now, if you won't take me on as a patient because you don't like my race, religion, skin color, etc., that's called prejudice, and that's illegal, so that's unacceptable. But if you just don't want to take any more patients, you don't have to. But let's say I come to you and say, I'd like you to be my physician, and you say yes, then I'm your patient. And although in the real world, there are ways to send patients registered letters, give them sufficient notice, and transfer them to another physician, not on the Step 2 CK exam. I'm your patient. The rule I want you to have in mind is borrowed from the old wedding vows. That is, till death do us part. I'm your patient. When? Until one of us dies. Now, what you don't know is I'm an annoying, difficult to deal with person. When I come and I sit in your waiting room, I insult all your patients so they become very distressed and some even leave. I'm abusive to your staff. And by the way, I don't bathe very regularly. I'm not due for my annual bath at least for another several months. So there's an aura that follows me around as I come into your office. What action should you take? Well, the option says continue to treat this patient as all other patients. Well, that's of course wrong. And the reason it's wrong is simple. When patients do something that is unacceptable, and patients have behavior outside acceptable bounds, the first thing you must do as a physician is tell them what acceptable behavior is. You don't simply tolerate misbehavior, you must ask them to behave within acceptable boundaries. You will sit with me and ask me to be nicer to the other patients in the waiting room, instruct me how to be nice and not abuse your staff, and you might actually get me to bathe so I don't have this aura everywhere I go. Suppose you try that and it doesn't work. You sit down, you give me instructions in terms of how my behavior should or could be better, and I don't change. In fact, I'm as abusive and obnoxious as I've ever been. Now, what action should the physician take? Well, there's an option that says now, continue to treat this patient like all other patients. Yeah, of course not. Of course not, because why would you inflict me on your staff? Why would you give me the opportunity to abuse your fellow patient or my fellow patients? The right answer here, of course, is find a way that I can receive medical care from you, but I don't abuse your staff and the other patients. And the solution would be something as simple as see me after normal office hours. Stay after, send the staff home, no other patients in the waiting room. Now I come in and I can get the treatment that I'm supposed to get. What I'm trying to suggest here is the underlying issue on the exam questions. Find a solution to the problem. Please note you must find a solution, not get rid of the problem. So the option that suggests you refer me to another colleague who is better able to deal with my kind of patient is clearly inappropriate. You're the physician, I'm the patient, you must provide the care. Suppose you're a male physician, a female patient comes to you and says, wow, doc, you're awful cute, let's get it on. And the physician is very attracted to this patient and, quote, even thinks he might be in love with the patient, unquote. What action should the physician take? Well, clearly, this kind of sexual contact between physician and patient is absolutely unacceptable. So what are you going to do, or what particularly are you going to say? How about you say to this patient something like, thank you, it's very flattering that you're attracted to me, but I'm married, I don't think this would be appropriate. Absolutely not. That's unacceptable. It doesn't matter that you're married, you don't tell them you're attracted, and it's not about you thinking it's unacceptable. It is absolutely inappropriate. Hey, how about we say to the patient, look, because I'm your physician, this is something that simply cannot happen, right? No, that's not an acceptable answer either, because even though you might not mean to imply it, that could be taken to mean, if I were no longer your physician, then this can happen. The only acceptable answer I can see is a clear, direct statement. Because I'm a physician now, this will never happen. Never. Because you're the physician, then this person is out of bounds for intimate social contact. Now, by the guidelines of the American Medical Association, you're not supposed to have intimate social contact with anybody who's been your patient in the last 2 years. For the USMLE exam, if they've been your patient ever, then they're always out of bounds from there forward. The ethical guidelines about sleeping with, having a relationship with the parents of a pediatric patient are a little bit less clear, but on the exam, I think that's also unacceptable. The real underlying problem here is, well, one, patients might view that you're giving preferential treatment to that person's child because of the relationship, and two, should something happen where the relationship does not continue, we're afraid that the care for that child might suffer. You're not supposed to be out of role. You're supposed to stay in the physician role, and you're not supposed to deal with patients in terms of intimate social contact. Even if a patient can't pay, that's no reason to stop being the physician. We have many patients, because of life circumstances or that they're in poverty to begin with, they simply can't pay. Understand, medicine has been for millennia considered a noble profession, and for a variety of reasons, but not the least of which is we treat people in need, not just people who pay. If you have a patient on the exam who has a medical need, and you're looking at the options that are figuring out how you're going to get paid, argue with the insurance company, petitioning the state legislature, you've clearly lost focus here, because your focus ought to not be on getting paid, it ought to be on getting the patient the care they need. Most physicians, you can make your own decision, of course, outside the exam, most physicians provide care for at least some patients who cannot provide compensation to the physician. It is simply the ethical position that the history of medicine requires. Not only are you not allowed to abandon a patient, you're not even allowed to threaten abandonment. And this comes out of your mouth before you even realize what it is that you've said. You have a patient, severely diabetic. You've described medication regimen, exercise that must be done, dietary change, daily testing. Your patient has done none of it. And in frustration, you're sitting with your patient saying, look, if you don't listen to at least some of what I'm saying, I don't see how I can continue to be your... I see where you want to go. I hear what you want to say. I'm even sympathetic about why you want to say it, but you can't go there. Even the threat of abandonment, unless you do what I say, I won't be your physician, is absolutely unacceptable. Once you're the physician, you're the physician. Number 12. Number 12 begins a discussion about informed consent. Informed consent is, of course, a critical issue in terms of healthcare practice in the United States. Let me begin with a simple overhead question to frame our discussion. The overhead question is, when do you get informed consent? And the answer should be obvious. Always. You're allowed to do anything to which the patient consents. You're allowed to do nothing unless the patient consents. Patients are the decision makers. You're not. They must be fully informed so then they can render the decision. Now, what does informed consent mean? Well, strictly construed, it means the patient has received and understood 5 pieces of information. Please note, and understood is a critical clause there. If you've gone over it and the patient didn't get it, there's no informed consent. If you've given the patient all the details written out clearly, legibly on paper, the patient signs the pages without reading it, there is no informed consent. Any question that suggests the patient has signed but didn't understand or read clearly is suggesting the patient did not get informed consent. What does the patient have to receive in order to provide informed consent? 1, they have to get a sense of the procedure. What is it you're going to do? 2, they have to get a sense of the purpose. Why do you think it should be done? 3, the benefits. What's good here? 4, the risk. What could go wrong? And 5, the one we most often neglect in the real world, the availability of alternatives. If we don't do this, then this is what else we have available to do. Please note, courts have held that the failure to lay out even a single available option vitiates informed consent. If you lay out all 9 of 10 options, you have no informed consent. That means clearly any test question where anybody suggests to you, let's not present an option, well, that's clearly a wrong answer. If a family member says this is too frightening, don't present it, you're going to present it. If an attending physician directs you as a resident not to present something, of course you're going to present it. Why? Because it matters that the patient get full information, not that the attending's direction gets satisfied. Now, the real world is not like that, so forget the real world. Let's just think about what the right answer will be on your exam. Those are the rules. The patient must receive and understand those 5 pieces of information. Here are the exceptions. The 4 times when we do not give the information that allows informed consent are: 1, emergency. If it's a life or limb-threatening emergency, we treat them now and tell them later. We don't slap them awake and tell them what we're going to do. We take care of them, save their life, and then we go ahead and provide the information. 2, waiver. A waiver is where the patient with full consciousness and forethought agrees not to get informed consent. When does that happen? Well, 2 times really. 1, research. I'd like to tell you the benefits and the risk of this drug, but you know what? We don't know them yet. That's why we're doing the research. Okay, the person says, and so now we can go ahead and include them in the research. Please note there's no informed consent because we haven't satisfied criterion, but we do have a waiver. The second time we get a waiver is often for surgery. We're going to go in and do a particular surgical procedure for a particular reason, but we often say to the patients, if it's not what I think it is and I discover something different, I'd like to take care of it when I get in there. If the patient agrees, then you have a waiver. If they don't agree, then you don't have a waiver. Now, important on the exam, don't assume that a surgical patient has given you a waiver unless the question explicitly says you have one. If it doesn't say you have a waiver, you don't have one. You must make sure that the question says it, or else it doesn't exist. So let's consider 2 simple cases. You've diagnosed a 23-year-old woman as having acute appendicitis, scheduled for emergency appendectomy. Go in, take out the appendix. It looks like it's fine, but hey, we'll let pathology worry about it. You can't help noticing when you're in there that the real source of this woman's pain is a nasty ectopic pregnancy. Do you deal with this ectopic pregnancy while you're in there? The answer, of course, is yes. And to justify the answer, it's all about emergency. While you're closing, while you're trying to go back and get her consent, the ectopic pregnancy could rupture. This could be a life-threatening event. Therefore, we're going to deal with it while we're in there, justified by the issue of emergency. Change the case, you change the answer. You've diagnosed your 23-year-old female patient as having acute appendicitis, a scheduled emergency appendectomy. You take out the appendix, looks fine, but hey, send to pathology, let them worry about it. Can't help noticing that the real source of this woman's pain is a nasty tumor on her ovary. Are we allowed to do anything to the tumor while we're in there? Well, let's be clear. You're not allowed to treat in any way. You're not allowed to shave the tumor so it doesn't impinge on other organs. What you are allowed to do, the surgeons have argued for this, and I agree, is you are allowed to biopsy the tumor. Now, there's some disagreement about this, but in general, I think the right answer on the exam is if they give you an option to biopsy, pick it. That's considered acceptable. It's not considered a treatment per se. You're simply gathering other information while you're in there. That said, without that waiver, we cannot do anything to treat the person's tumor. You can't reduce it in any way. You can't try to rearrange the internals in some way. You must simply leave things as they are and then wake the patient up, full informed consent, after all the anesthesia is cleared, before you can go in and do anything. And notice that informed consent you provide must include all possible alternative interventions, including non-surgical interventions, before you go ahead and proceed. The third exception to informed consent is incompetence. If the patient is not competent by age, court designation, or clear behavior, then they cannot provide informed consent. And finally, therapeutic privilege. Therapeutic privilege is your right to deprive the patient of autonomy in the interest of their health or the health and well-being of other people. This is why we take someone who is violent and put them in restraints and pump them full of Haldol. Even if they're screaming, no, no, let me out of here, we go ahead and we give them the medication anyhow. Why? This is easy. Stop harm from happening. There's that doctrine again. You want to make sure that harm does not occur. We will stop people from hurting themselves and stop them from hurting other people. That's the meaning of therapeutic privilege. Number 13 is an easy rule. It simply reminds you that this is the U.S. medical licensing exam. This is not an exam specific to a given state, so what you're tested on must be at least consensual across the 50 states. Therefore, things that vary widely from one state to the next cannot be tested. What about abortion law in the second 2 trimesters? They can't ask because they can't possibly score that question in any sort of consensual way. What about what is the, legal age for drinking? Well, there's some variation between states. And so between 18 and 21, there could be variation. They simply can't ask. What about what is the level of blood alcohol you have to have before you're legally drunk? Again, that changes from state to state. And frankly, in some states, it changes as each year passes. And so once again, you can't be tested on this. When you see a lot of variation, rather than that causing you anxiety, it should be a source of comfort. Because if they can't agree, they can't ask. Number 14. 14 talks about Good Samaritan laws. Strictly construed, Good Samaritan laws are supposed to help limit liability when physicians stop to help in non-medical situations. Read accident situations. So, Good Samaritan laws, let's talk about the key issues involved here. First, you have to stop and help. You're driving along country road, there's a car accident, you're the only person for 100 miles around. You're a fully licensed doctor. Do you have to stop to help? The answer, of course, is no, you do not have to stop to help. If you simply don't want to, you don't have to. The law does not require that you do. Now, ethically, your action is, of course, clear here. Of course you should stop. But again, by law, you do not have to stop and help. But we'd like you to stop. We think it'd be a better world if you stop. And by the way, if it's ever me, please stop. But we're not going to force you to stop. What we are going to do is remove a barrier that might cause you to keep on driving and not stop. What's the barrier? You're afraid of being sued, aren't you? You're going to stop and try to do medical treatment out here in an uncontrolled setting. In this uncontrolled setting, anything could happen, adverse consequences are higher, and you might be sued. This is where the Good Samaritan law kicks in. If you stop and help in this non-medical setting, and you stay within certain very broad boundaries, then even if every patient you touch dies a horrible, agonized death, you're absolutely shielded from legal liability. And I mean the shield is absolute. What are the boundaries you have to stay within? First, the actions you do when you're treating this patient must be within your area of specific competence. Now, please note, we expect all physicians to have general competence across a broad range of areas. Even a psychiatrist can deliver a baby. Even somebody that's made their living as a dermatologist can handle even minor surgical procedures such as a tracheostomy. We assume that everybody has the basic minimal skills. You've all passed the USMLE sequence. You've all been to the same rotations going through medical school. What I mean here is, suppose you made your living as a dermatologist over the last 20 years, and you're very good at it, and now you decide this patient needs on-the-spot open brain surgery. No, that's probably out of line here. But as long as it's within what you feel is fairly competent area, you can feel free to go ahead and do whatever procedure you think is indicated. Second, the procedures you do must be standard accepted procedures. You have to do what every other physician pretty much in the same situation would agree, that's the thing I would do. This is not the time to do anything innovative. This is not the time to do something odd, physical, that you wouldn't do in normal circumstances. You have to limit yourself to kind of standard accepted procedures that all physicians would countenance. Third, you don't have to stop, but you have to stay. Once you stop, you're committed for the duration, and the duration is until you're relieved by competent medical personnel. Another physician certainly qualifies as competent medical personnel, but so do the ambulance guys and gals, the EMTs. For trauma situations, they're considered competent medical personnel. Under strict construction, black letter law they call it, the ambulance pulls up, you can help load the patient onto the gurney, put them in the back of the ambulance drives to the hospital, you can get in your car and drive away, and that's fine. That's not, of course, a good answer on your Step 2 CK exam. The law allows you to drive away, but ethical obligation is certainly higher than that. So what are you supposed to do? Well, that's easy. You're supposed to help them load the patient in the back of the ambulance and then get in your car and follow the ambulance into the hospital. Yeah, of course not. Because if there's a crisis in the ambulance, you're driving behind in the car, you're essentially useless. You can't provide any useful medical intervention for your patient. So what's the best answer? Clearly, leave your car by the side of the road, get in the ambulance, and drive into the hospital with the patient. Absolutely. If you're worrying about your car, you're worried about the wrong thing here. Leave the car, go with the patient. That's the right answer. And if you say I wouldn't do that in the real world, we're not talking about the real world here. We're talking about what's the right answer as you're answering your exam question. Finally, no compensation can change hands if you wish to be protected by the Good Samaritan shield. Once any money, any compensation of any kind is exchanged, it's no longer Good Samaritan, it's fee for service. And all the issues of legal liability come, well, cascading down. You stop to help a man whose car is overturned in the median strip, pulled him out of the car, splinted, elevated his arm, which you believe is broken in the appropriate manner. The man is sitting on a grassy embankment, and as he begins to regain his composure, he reaches into his pocket and pulls out a wad of $100 bills, pulls off one with his teeth, hands you 100 and says, "Go buy yourself lunch." Do you take the money? Of course not. As soon as you take the money, Good Samaritan is gone. We're now on a fee-for-service basis, and the guy gets a pulmonary embolism and dies tomorrow, you're liable for that. Of course not. The idea here is you stop to help out of the goodness of your heart, so leave it there. Turn down money, turn down gifts, turn down anything that might be construed as compensation in order to be protected by the Good Samaritan shield. Number 15 is a critical rule. 15 reminds you that confidentiality is absolute, ladies and gentlemen. This is where paranoia is appropriate. You will not tell anybody anything about any patient ever under any circumstance. Yes, I know there's exceptions. We will get to that. But the place to start is confidentiality is absolute. Wait, does that mean I can't get a consult with another physician about my patient? Sure I can, but the physician I gained the consult from is now bound by the same web of confidentiality that I am. Besides, that's not the exam issue, whether or not you get a consult. The exam issue is where you get the consult. Well, we're sitting having lunch in the hospital cafeteria, and I'm simply discussing the patient with my colleague. Absolutely not. You could easily be overheard. You're in a public setting. How could that at all be considered appropriate? It's simply not. You're in the hospital elevator, riding up between the first floor and the 10th floor to see your patient. As we're riding up in the elevator, just me and my colleague, nobody else in the elevator, I'm briefing my colleague on some of the new information about my patient's condition. Absolutely not. Wait, there's nobody in the elevator but just us two. Most elevators have cameras, most have microphones, and if you're not thinking this way, you're not thinking paranoid enough. Confidentiality is absolute. You have a very well-organized office. Everything digitized, everything electronic. Your patient records kept on computer, and you have a wonderful T1 line connecting to the outside world, so you can communicate with patients by email, with insurance companies, with specialists. It makes for a highly efficient practice that does good service for your patients. By the way, what's your firewall like? If you have no idea what I'm talking about, boy, did you just screw up. Because you just told me that anybody with a modem in Hyderabad, India, can download your patient's records, slap them up on a website, and if you're not thinking this way, you're not thinking paranoid enough. It's not enough to not tell. You have to make sure nobody can find out. You're supposed to anticipate how people might try to breach the protection and make sure that breach doesn't happen. You're going home after a long night on call for a much-deserved meal with your beloved. As you're sitting down to dinner, say to your spouse, "Oh my goodness, as I was leaving the hospital today, guess who I just saw? Arnold Schwarzenegger came." You can't say that. You can't say you saw Arnold come into the hospital. Why? You just breached confidentiality. Let's be clear. Even the janitor who swabs the floors at the hospital can't say he saw Arnold Schwarzenegger this day, because that's a breach of confidentiality, and that's actually a firing offense for most hospitals. You're not allowed to say, even to your spouse, absolutely. Confidentiality is tight, absolute. This is where, once again, paranoia is appropriate. You get a subpoena that asks you to show up at the local county courthouse and testify next Friday about one of your patients. Question 1, do you show up next Friday at the courthouse? Of course you do. It's the only legal advice you're getting from me in this whole segment. If you get a subpoena, show up. You got a subpoena, you have to show up because it's simply required. It compels your presence. Question 2, do you testify about one of your patients? Of course not. When asked a question about your patient, you will reply, I'm sorry, Your Honor, but because of physician-patient confidentiality, I respectfully decline to answer. The judge says, well, would you simply confirm that Mr. Green is one of your patients? To which you will reply, I'm sorry, Your Honor, but because of physician-patient confidentiality, I respectfully decline to answer. Please be clear, even the fact that someone's your patient is confidential. Whether or not they kept an appointment last Tuesday is confidential. If the patient says it's all right for you to tell, then I can tell. But without that release from the patient, I can't say. Why can't I simply answer questions about whether or not this person is my patient? It's fairly obvious, I hope. Court records are public documents. They can be searched by people that have the wherewithal to do so. If you're a cardiologist and you say, yes, Mr. Green is one of my patients, you basically told the whole world that Mr. Green has a heart problem. You will not tell anybody anything under any circumstance, except the single exception to breaking confidentiality is a big exception. Threat of harm to self or others. If you think the patient is going to hurt themselves, you, or anybody else in the known universe, not only can you break confidentiality, no, you must break confidentiality. The way I want you to think about this is simple. If there's danger to self or others, there is no more confidentiality, period. You will do anything you need in order to stop harm from happening. It will never be a defense to say, well, I would have intervened and stopped that, but confidentiality prevented me. Why is that no defense? Because if you needed to intervene, there is no confidentiality. You have to stop harm from happening. Confidentiality, a big, important rule. Stopping harm, an even bigger, more important rule. Stop harm from happening. Now, the rule as to whether you breach confidentiality has to be that the harm we're thinking about is, well, not general, but specific, focal. The phrase we use is specific harm to a specific person. What I mean there is if you think this person is mean and might one day eventually hurt somebody, there's just nothing there that's actionable, nothing you can do something about. But if you think this person is going to go out and hurt this particular person, or is likely to do this particular action that will cause harm, that compels you to act. Breaching confidentiality in this instance is not a choice, it's an obligation. What about infectious disease? What about if a patient has some sort of infectious disease? Well, we're going to make sure that that disease does not spread. We're going to stop harm from happening. Let's frame a particular case. A husband, a man, comes in and has gonorrhea. You treat his gonorrhea, and he says, thanks, doc, I appreciate it, but please, you can't tell my wife. I mean, I had this extramarital affair. I'm sure that's where I got this sexually transmitted disease, but my wife, she wouldn't understand. Please, you can't tell my wife. The physician's next course of action is, all right, well, let's back up here for a second. Everybody needs to understand clearly the wife finds out. There is no question the wife finds out. Why do I say there's no question? Because in addition to treating him for the gonorrhea, gonorrhea is a mandatory reportable disease. After you treat him, you will contact public health. Public health with this information will do a contact tracing. They will inform and try to get tested all of this person's sexual partners. So they will make the assumption that he's sleeping with his wife, and therefore she will be contacted. So the wife finds out. The fantasy your patient has that the wife won't find out is simply not a possibility. So the discussion with the patient is not should the wife find out or not. You ought to be beyond that. The discussion with the patient is what's the best way for the wife to find out. The wife needs to be told, how are you going to do that? Are you going to pick up the telephone, call the wife and say, hi, you don't know me, but maybe you have gonorrhea? I don't see that as your best course of action, do you? The right way to handle this is husband, wife, in your office. He can tell her you're there to mediate any tension that might provide and to make sure the wife gets the medical care and attention she requires. The issue here is not whether we tell the wife. The examination, of course, is what's the right way to tell the wife. And in your presence, with the husband present as well, is clearly the best solution. Number 16. Number 16 reminds us that patients should be given the chance to state do not resuscitate orders and physicians should follow them. We added this to your preparation materials when a series of articles were published that tell us the following. 1, physicians don't talk very much to patients about do not resuscitate orders, and 2, where they exist empirically, physicians don't usually follow them. Well, the way the exam works is when that kind of research is published, you know they've gone out and wrote a bunch of questions in this area to make sure you know what the right answer is and what the right action is to take. So let's walk away down through the drill regarding do not resuscitate. The first question is, when do you have a conversation with your patient about the do not resuscitate wishes? What's the occasion for that conversation? The right answer is, of course, the very first interaction with the patient. This is part of your initial history and physical. In short, I'm tasking you with this notion. If you don't know your patient's do not resuscitate wishes, you've already screwed up because you don't know because you didn't ask. You're supposed to ask. The options that we often use in the real world, telling the patient when they're hospitalized, telling the patient when they get their diagnosis, telling the patient when we believe they're terminal, are not acceptable choices. You must learn about this up front when the patient has a chance to think, reflect, and unemotionally consider what their wishes are. Now, when you have a conversation about do not resuscitate wishes, make sure the patient understands what you're talking about. What we mean when we say do not resuscitate is no, quote, heroic measures. It does not mean terminate existing treatment. It does not mean take the patient off of drugs. We can even begin new treatment or even do surgery. What we won't do is, in the language I hope you're used to, call the crash cart. We will not, for example, restart the heart if the heart stops. We will not be aggressive in terms of intubating them to maintain breathing or keeping them alive on a respirator. Without modification, do not resuscitate doesn't mean stop treatment. It means no heroic measures. Now, make sure your patients understand this when you have the conversation. If you simply walk in and say to a patient, what are your wishes in terms of do not resuscitate, patients often don't understand what you mean, and they think, we've discovered, that you mean you're going to stop treatment, take away oxygen, no longer provide IVs. You must be explicit in terms of what you mean when you talk about do not resuscitate. I'll also point out to you that on a number of exam questions, they don't simply say the patient has do not resuscitate order, they have specifics. You may get cardio do not resuscitate, which means you can intubate, put them in a respirator, but you don't restart the heart. You may see pulmonary DNR, which means you can restart the heart, but you're not allowed to put them in a respirator, for example. Your job is to read the specifics and pick the option that matches those specifics. Number 17, committed mentally ill patients retain their rights. Being committed does not mean you're incompetent. We're going to once again assume competence here. Being committed means you're mandated to a locked care facility. And in that locked care facility, you must, 1, have treatment available, 2, have the right to refuse treatment, 3, you retain all of your other civil rights, including the right to get married, the right to get divorced, the right to conduct business. You even get to vote, for God's sakes. Yes, I just told you the committed mentally ill get to vote in the United States. Explains a lot, don't you think? Being committed doesn't mean they lose decision-making. It means they can no longer come and go as they please. So if I have a schizophrenic patient committed to a locked unit, I walk up to him with his daily dose of antipsychotic medication, and I say to him, here's your daily medication. And he says back to me, I don't want that today. Do I give him the medication? Of course not. If he's able to articulate that clearly, I don't want the medication, there's no basis for forcing this on him, because a competent patient has an absolute right to refuse medical treatment. Now, were he violent, aggressive, a danger to self or others, then I might medicate in order to control his behavior, but that wasn't the original scenario I presented. Courts commit, physicians detain. Rule number 18 reminds you that you are obligated to detain patients to protect them or others. This is not really, again, a choice, it's an obligation. You're allowed, most states, 48 to 72 hours to hold on to a patient in order to prevent them from hurting themselves or somebody else. After that point, the patient's allowed to have a jury trial which will determine their status, decide their competence in essence. Please note, a jury trial, not simply a trial by judge, because we want to make sure that this important decision is being rendered by not an individual who might be biased, but by the collective wisdom of the 12 people on the jury. Courts commit, physicians detain. Any test question that says the physician should commit this patient is clearly wrong just on the basis of that single word. You're not allowed, you're not authorized, you're not qualified to commit. You can detain. And you, of course, must detain. You just examined a patient and discovered this patient has the most virulent tuberculosis you have ever seen. Left unchecked, this is likely to go running rampant through the general population. The patient, when informed about this diagnosis, refuses treatment and demands to be let to go home. Question 1, do we treat the patient? The answer, of course, is no. Why? Competent patients have an absolute right to refuse treatment. Question 2, do we let the patient go home? The answer, of course, is no. This patient is now in indefinite quarantine. We will not force treatment, but we will not let this person wander and spread the TB within the general population. The idea here is patients get to deny treatment, right, but they don't get to go out and spread infection. That's right as well. Detention, quarantine provides the optimal solution. Number 19, healthcare professionals who pose risks to patients should not be around patients. That ought to go without saying, but I want to make sure we're clear about the issue here. How do you know when a healthcare professional is a risk to patients? It's easy. If you think maybe they're a risk, then they are. You just answer the question. You don't need a committee to agree with you. You don't need a panel of experts to sign off. If you think there's a problem, there's a problem. You must take the appropriate action. What are the kind of things that might cause you to get a fellow physician, for example, from seeing patients? Well, if you think this person has a substance abuse problem, alcohol or any other drug, they shouldn't be seeing patients. If you think this person has a psychiatric problem that is going to impede their ability to be a good, successful, competent physician, they shouldn't be seeing patients. If you think this person is infected in some way and might spread the infection, they shouldn't be seeing patients. If you think this particular physician is incompetent, your opinion is all that matters here, they shouldn't be seeing patients. The rule I want you to have here about when action is required is the same rule we give you when you're dealing with patients that might be suicidal. We've told you, if you're wondering whether or not you have to act on this patient who might be suicidal, the answer is, if you're asking yourself the question, of course you have to act. To ask the question is to answer the question. The same thing holds for intervening with a colleague. If you're wondering whether or not you need to do something to stop this colleague from seeing patients, the answer is always yes. Why? Because we'd rather err on the side of removing a physician from contact when that wasn't required than err on the side of allowing the contact when, frankly, we should have cut it off here. Make sure that anybody you think is a danger to patients has no contact whatsoever with patients. Which brings us to the last and final rule, number 20. The last rule here is really a summary rule. This is a rule that pulls together a number of the threads that have been woven through the other 19 rules that we've talked about. The issue here is to pick the best possible answer for your exam question. And the best possible answer is not merely the minimum the law requires, it's the maximum that ethics dictates. Sitting looking at two options, one that satisfies the law and the other one that goes far beyond what the law requires, you ought to know by now what the right answer is. You go beyond the law. In trying to decide what is acceptable, acceptable is not good enough. Your job is to do the maximum. It's to serve the patient. It's to make sure the patient gets exactly what they need, and the focus is always on the patient and not on you. So, what's your process on these ethical legal questions? You're going to read the question, okay. You're going to stop and think, what is the rule that applies? Okay. You look down through the options and think about what option satisfies the rule, great. And then, one last thought, before you key in the answer, say to yourself, what would Mother Teresa do in this instance? And then, that's what you pick. Because the ethical standard expected of you on the exam is, I hope I've illustrated, stunningly high. Don't answer these questions based on what you've seen. Don't answer these questions based on your gut. Answer these questions based on what the rules are. It's not that physicians in the real world do everything wrong. It's that when physicians in the world do everything right, they don't ask you that on the exam. What they tend to test you on is when physicians get it wrong. You are supposed to know better. You're supposed to get it right.